Hi, Mike Gibson, Tom 2, joining you live from SCAI 2018. We're talking about the treatment of pulmonary embolism and a new randomized trial that you just presented here, the FLAIR trial. Tom, talk to us about this new device and new approach.
Absolutely, Mike. As you know, pulmonary embolism is a very important clinical condition that I think all cardiologists should be concerned about. It's probably the number 3 after myocardial infarction and stroke in terms of acute cardiovascular conditions that cause morbidity and mortality. Our thinking about pulmonary embolism has been rooted in the past, with the majority of patients being treated with anticoagulation alone, which works in many cases, but unfortunately the risk of morbidity and mortality is still unacceptable in my book. Prior to this, there have been some research regarding catheter-directed therapies, but those all require the use of thrombolytics, and as we know, thrombolytics carry both a cost and a risk of serious bleeding, if not fatal bleeding. The flow retriever procedure, which was studied in the FLAIR trial, is a novel device which is a mechanical thrombectomy system that does not use thrombolytics. It is a system in which there is a large bore catheter directed from the femoral vein into the pulmonary artery that is then used to deliver a wire mesh device that engages the clot, and then the clot can be physically removed, resulting in acute resolution of RV strain and physical removal of the clot, similar to surgical-like results.
Interesting. So what was your primary endpoint of the study?
This was a feasibility study looking at safety and efficacy of this device. It was a multi-center prospective non-randomized study. The efficacy outcome was the reduction in RV to LV ratio, which is the standard measure by which the FDA assesses these devices for approval. The reason why it's used is because acute pulmonary embolism typically results in RV strain, which results in RV dilatation, compressing the LV, and we frequently see RV to LV ratios that go from less than 0.9, which is normal, to ranges of about 1.5. What we saw in this trial was that there was an average reduction of the RV to LV ratio of 0.4, which was favorable compared to current devices that are used to treat pulmonary embolism.
So what's your next step? What are you doing in the future?
Well, I'm also pleased to say that there was a safety endpoint which we met as well, that the device was proven to be safe with a very small number of adverse outcomes and really no device-related complications. I think the next step for this trial would be to look in a broader fashion at more tangible clinical and hemodynamic outcomes to really firmly establish a non-lytic therapy for the treatment of acute pulmonary embolism.
Wow, exciting stuff, Tom. You know, I think lytics work, but the downside is a lot of bleeding. It's great to see a non-lytic approach. Congratulations. Look forward to seeing the future iterations of the device.
Thank you, Mike.
Thanks for joining us, and thanks to all of you for joining us here live from SCAI 2018.